Now we come to the section on treatment of atrial fibrillation. What are the objectives of treatment of atrial fibrillation? Fundamentally, we have to relieve the symptoms of the patient. We should prevent recurrence of atrial fibrillation. We should prevent the development of heart failure due to atrial fibrillation. Most importantly, prevention of systemic or pulmonary thromboembolic complications. The third important thing that can happen to the heart due to atrial fibrillation is the tachycardia of atrial fibrillation can induce myocardial remodeling. Tachycardia induced myocardial remodeling and changes which will become permanent. We would like to ward off those things. So, in nutshell, relief of symptoms, prevention of recurrence and heart failure, prevention of systemic thromboembolism and prevention of tachycardia induced myocardial remodeling are the three goals that are important, that are almost the categorically stated goals of treatment of atrial fibrillation. What are the management strategies we have in hand to achieve the above objectives which are listed in the previous slide? One, we can control the ventricular rate by using rate control methods, or we can make the atrial fibrillation revert back to sinus rhythm, that is called the rhythm control by drugs. Or the third thing is prevent thromboembolic complications by use of anticoagulants such as warfarin, keeping the international normalizer ratio between 2 and 3, or attempt electrical or pharmacological cardioversion to revert to sinus rhythm. These are the only things we have in our hand: rate control, rhythm control, anticoagulation, cardioversion, and of course modifying the underlying structural heart disease is essential strategy for management of the underlying causes like CAD or LVH or LVD or a valvular disease, rheumatic disease, thyrotoxicosis, whatever it is. Once we diagnose a patient with atrial fibrillation, the question is quickly assess and see whether he is hemodynamically stable or hemodynamically unstable. Hemodynamic stability means good blood pressure, ventricular rate not very fast, ejection fraction is good, oxygen saturation is good, no shock, patient is comfortable. Hemodynamic instability, fall of blood pressure, severe tachycardia, decreased ventricular filling and emptying, and then fall of ejection fraction, shock, and then decreased oxygen saturation. All these point to hemodynamic instability. A patient with atrial fibrillation who has hemodynamic instability must be immediately submitted, if possible, for cardioversion so that he can be saved from further danger. In patients who are hemodynamically stable, we have two main types of approach. Is the patient already anticoagulated for some reason, and if so, is the INR between 2 to 3 for more than 3 weeks? If the INR is between 2 to 3 for period of more than 3 weeks and is already anticoagulated, he can be taken up for a cardioversion procedure, which we will see in the next slide. If he is not anticoagulated at all, or if his INR is subtherapeutic, that is less than 2 for the past 3 weeks, he requires a different management strategy. Okay, patient with atrial fibrillation diagnosed, hemodynamically stable, hemodynamic instability excluded, patient is not in grave danger, already anticoagulated, INR is between 2 and 3, that is in therapeutic range for a period of more than 3 weeks. Attempt cardioversion if the facilities are there, either chemical or electrical, or do rate control, and then outpatient follow up in 24 to 48 hours about the outcome. So, the two options, either to go for cardioversion or to give him rate control measures, which we will discuss subsequently, mostly beta blockers or calcium channel blockers. OP follow-up is enough and they need not be admitted. Supposing the patient has got atrial fibrillation, hemodynamically not stable, then we have done cardioversion. For those who are hemodynamically stable, not anticoagulated at all, or INR is subtherapeutic less than 2 for the last 3 weeks, then you institute anticoagulation, then attempt the rate and also associated rate control measures. Straight away they are not taken for cardioversion because of the risk of embolic complications. Or if we think of cardioversion as an option, we have to do a transesophageal electrocardiography and rule out a left atrial clot, and then of course attempt cardioversion. Both these groups, either with and without cardioversion, they have to be followed up, and warfarin is a must even after cardioversion. They must be given before as well as after cardioversion. The anticoagulation has to be continued, and OP follow is adequate for such patients after the procedure is done or after rate control and anticoagulation is instituted. How about recurrent atrial fibrillation? We do have patients who have recurring attacks of atrial fibrillation. Then immediately, are there minimal symptoms or disabling symptoms? If there are minimal symptoms, warfarin and rate control and no preventive anti-arrhythmic drug treatment is required. If the patient is not symptomatic, rate control measures, institution of anticoagulation, oral anticoagulation by coumadin derivatives, that is warfarin, no AADs, that is anti-arrhythmic drugs. The patient has got disabling symptoms. In addition to warfarin and rate control, patient requires a rhythm control drug, anti-arrhythmic drug treatment for prevention of recurrent arrhythmia. So, this is the strategy for recurrent atrial fibrillation. There is a lot of debate whether we should prioritize rate control or rhythm control. Actually, it is an arrhythmia, so commonly we understand, we may think that rhythm control may be more essential than rate control, but it is not so. Integration of several factors is important. What is the age of the patient? What are the degree of symptoms? The likelihood of success of cardioversion, the status of anticoagulation, the presence of atrial thrombus, the presence of comorbidities. All these decide whether we will go for a rate control strategy or for a rhythm control strategy, which we will be looking at in the subsequent slides. Then the debate is, which is important? Is it controlling the rhythm or bringing down the rate or anticoagulation? Certainly, anticoagulation is the most important strategy that should be employed almost for all cases of atrial fibrillation. Rate control will be the important option alongside the anticoagulation, rhythm control only in selected cases. The FM trial, atrial fibrillation follow-up information rhythm management trial. So, this FM trial has very clearly documented that there is no extra benefit by doing rhythm control once we anticoagulate the patient and use the rate control measures. RACE trial, RACE is rate and RA is rate and CE is electrical cardioversion. So, comparison of rate control versus electrical cardioversion. This trial, all these have proved that anticoagulation and rate control are far more important than attempting a rhythm control. The younger the patient, the better will be the option of rhythm control. Comorbid conditions, older patients, rhythm control may not last long. Even if you control the rhythm, you will again revert back to atrial fibrillation. So, rate control will be the best option. Anticoagulation is a must, whether it is an young patient or an old patient. INR above 2 is therapeutic, anything less than 2 is subtherapeutic.